welcome you all for day 2 live webinar, Cancer Conclave 1. And for the welcome note and further, I would like to invite meeting convener, Dr. A.B. Dubey, sir. Sir is Senior Consultant and Unit Head Medical Oncology and Oncology, Medical Hospital, Delhi. So over to you, sir, for further procedure. Thank
Uh, Good evening, everyone. Thank you, Aram. And I hereby at the outset thank everyone here who have taken out their precious time for this educational event. So to start, in the interest of time, we'll start the first talk. And first talk will be delivered by Dr. Megha Manhas, who's a senior resident with me at Metro Hospital and Cancer Institute. She'll be speaking on present and future landscape in HER2-neu positive breast cancer. As we all know that HER2-neu positive breast cancer accounts for around 25% of all breast cancer. So she'll be speaking about the evolving landscape in HER2-neu positive breast cancer. Dr. Megha, over to you.
Good evening, sir. Is my screen visible?
Yeah, you are audible,
Yes, ma'am.
but your slides are yet not. Yeah, your slides are also visible. You are also audible.
So I'll be talking about present and future landscape of HER2 positive breast cancer management. So is rising fast, with the incidence being around 2.3 lakh in current year as compared to 1.8 in 2015. And talking about HER2 positivity, approximately 20 to 25% of breast cancer patients have tumors that are HER2 positive. Now, let's have a glimpse of present and future landscape of management of HER2 positive carcinoma. First, neoadjuvant therapy. So, which patients should be considered for neoadjuvant therapy in early breast carcinoma? So, one is high tumor volume to breast ratio, lymph node positive disease, high risk features including high grade hormone receptor negative, HER2 positive or triple negative breast carcinoma, and also younger age at diagnosis. Now, patients who have tumor 2 or more than 2 centimeter diameter or who have nodal positive disease, they should receive pertuzumab in addition to trastuzumab and neoadjuvant chemotherapy. Neosphere study had taken up HER2 positive early breast carcinoma cases and randomized them into 4 arms: TH, THP, HP, and TT. And locally advanced breast carcinoma cases were randomized arms where dual HER2 blockade was studied in addition to different chemotherapy regimens, either FEC, docetaxel, or docetaxel plus carboplatin. Now, it was seen that in Neosphere study, addition of pertuzumab to trastuzumab increased PAT-CR rate regardless of hormone receptor status. And in Trifina study, it was seen that dual HER2 blockade provided clinical benefit regardless of chemotherapy partner, with the highest benefit being in T. And the preferred regimens for HER2 cases are plus trastuzumab, TCH, TCHP, or TDM1. And it should be noted that all preferred regimens are non-anthracycline based. Forget study had studied dual HER2 block de-escalation. So this trial investigated the role of chemo de-escalation in patients who showed early metabolic response on PET scan after 2 cycles of either TCH or PH, that is dual HER2 blockade without chemotherapy. Proportion of patients, around 80%, had responded on PET-CT with dual HER2 blockade without chemo group B. And the rate was around 38% in FDG PET responders in group B. The result was statistically significant. Comparing the two groups, ECHP arm had higher CR rate as compared to group B. However, there was reasonable outcome in group B as well. And comparing PET responders versus non-responders, so in both the groups who showed early metabolic response, they had higher PR as compared to those who respond. Coming to efficacy, so dual without chemotherapy had excellent outcomes across all endpoints with at least comparable or numerically superior outcomes as compared to group A. And coming to this, so dual HER2 blockade without chemotherapy had lesser grade 3 to 4 treatment emergent adverse events, with these being 12.8 and around 65% in group A arm. And there was no related serious adverse event noted in group B. To conclude that this trial met its secondary endpoint in HER2 positive breast carcinoma, with 3-year IDFS being 98.8% and in patients who responded on PET-CT, and there were no unexpected safety signals. So this strategy identified approximately patients with HER2 positive early breast carcinoma who can safely omit chemotherapy and thereby reducing toxicity. Coming to adjuvant setting, so presently we have affinity trial which had randomized patients after surgery, HER2 positive breast cancer patients after surgery to either trastuzumab plus chemotherapy or addition of pertuzumab to trastuzumab and chemotherapy. So it was seen that with addition of pertuzumab, there was a trend towards improved overall survival, but it was not statistically significant, and the absolute benefit in 8-year overall survival was just 0.7%. And it was seen that with patients with nodal positive disease had they had derived the most of the addition of pertuzumab, and the result was consistent and increasing over time. As we can see that initially it was 3.2%, then 4.5, and then 4.9%. However, node negative disease did not derive any benefit from the addition of pertuzumab. Hormone receptor positive or negative disease, they had comparable outcomes with the addition of pertuzumab. So it was irrespective of hormone receptor status. Now, patients who receive neoadjuvant therapy and then undergo surgery, and when talking about adjuvant setting, if nodal disease was positive initially at the time of diagnosis, then addition of pertuzumab should be done to trastuzumab. In all other cases, pertuzumab addition is plus minus. That is, you can either add or not it with trastuzumab. Coming to phase 3 Peony trial, which had studied the role of neoadjuvant adjuvant pertuzumab positive early breast carcinoma patients in Asian population. So in this trial, patients were randomized to either trastuzumab plus docetaxel or addition of pertuzumab to trastuzumab and docetaxel, followed by surgery. So it was seen addition of pertuzumab, there was an improvement in total PAT-CR, 5-year disease-free survival, local regional recurrence after surgery, distant metastasis with or without CNS metastasis. Coming to Destiny Breast 05, which is an ongoing trial for breast carcinoma cases with residual disease in either breast or regional lymph nodes following neoadjuvant, they have been randomized to either trastuzumab deruxtecan or TDM1. And this is another ongoing trial, Compass 2, in which HER2 positive breast carcinoma cases after chemotherapy with THP for 4 doses, they undergo surgery. If PAT-CR, then HP is completed for 1 year, or if residual disease, then these are again ran to either TDM1 plus tucatinib for 4 doses. Coming to metastatic setting, so Cleopatra had established the role of addition of pertuzumab to trastuzumab plus docetaxel. So it was seen that with addition of pertuzumab, there was an improvement in overall survival as well as progression-free survival, and the results were statistically significant, and the hazard ratio was 0.69, and the objective rate with the addition of pertuzumab was around 80%. Patients with HER2 positive breast carcinoma cases, the disease relapses after 12 months of completing adjuvant therapy, or if there is newly diagnosed stage 4 disease, then THP is to be given for 6 to 8 cycles, followed by trastuzumab, pertuzumab until progression. or if there is relapse within 12 months after completing therapy, and if there are no CNS mets, then TDXT is the first line. If there are active CNS mets, then tucatinib, capecitabine plus trastuzumab is to be considered. Uh, in this trial, addition of eribulin in HER2 metastatic breast carcinoma cases, and it was seen that with addition of eribulin, there was an improvement in progression-free survival till 14 months. However, the hazard ratio was just 0.95, and the overall survival had not reached with eribulin group, with the hazard ratio being 1.09. Destiny Breast 09. This is a trial for advanced or metastatic breast carcinoma cases in which patients were randomized to either TDXT, pertuzumab, or THP. However, none of the regimens they have shown big clinical benefit compared to Cleopatra regimen, that is dual HER2 blockade with docetaxel. India is now privileged to have its first pertuzumab biosimilar. And there was this phase 3 trial that had evaluated ZRC3277, pertuzumab biosimilar, in comparison with Perjeta, that is pertuzumab, in HER2 positive metastatic breast carcinoma. So to conclude, as now increasing, and as per Newsfare and Trifina, eligible patients, they should be brought under the neoadjuvant first approach. And de-escalation strategies are being explored extensively, and that will be the part of personalization in coming time. And as per affinity, positive long-term data for pertuzumab in upfront adjuvant setting should be considered for node-positive patients particularly. And the new data through Peony trial may add some confidence in adding pertuzumab in neoadjuvant and then adjuvant as continuation. However, pertuzumab to get with taxane, it remains the undisputed standard of care in metastatic breast carcinoma first line, as per Cleopatra. Thank you.
Thank you, Dr. Megha, for enlightening us the role of pertuzumab in HER2-neu positive breast cancer in various settings. So next, I would like to call my friend Dr. Kaushik to speak on ASCO GU updates. So over to you, Dr. Kaushik.
Thank you, sir. Just sharing my screen.
Yes, you are audible and your screen is also visible.
Thank you, sir. Thank you for the opportunity to come to visit. So I will be talking on few snapshots of the various phase 2 oblique phase 3 data which has been presented in ASCO GU Symposium 25. So it will be a snapshot and the conclusion so that it may raise some interest in going back and looking into the entire study article. So starting with this first one, this was a data by the Zhao et al. Which showed the gene signature predictor of dose response to prostate radiation. Those are PORTOS in a phase 3 trial. PORTOS is a prostate cancer radiation therapy outcome score. This is a gene expression score like what we do in on the FDA. So this is the prostate cancer radiation therapy outcome score, which is again done in a Decipher platform, where it has been seen in this study. It helps us to predict the dose response, whether it can be in a salvage setting or a definitive setting. So how the more the PORTO score, it has been shown the greater dose given, the benefit is on higher side. So also help us to guide the escalation and de-escalation of the radiation dose in this setup of the therapy. So it has to minimize the adversity of the toxic event. So overall, there are much more studies coming up investigating the role of this score, particularly the PORTO sign with respect to the role of EDT, toxicity are ongoing. One of them, name is the phase 3 is the Altitude 0126. So this is the presentation by the author regarding the role of PORTO, which is upcoming in this era. So the next one to go with the prostate cancer was the radical prostatectomy versus radiotherapy in high-risk prostate cancer. Again, it was a IPD from the two phase 3 RCTs which has been presented by the Soumyajit Roy et al. Group, where it was seen that out of the present, we have multiple current recommendations from NCCN. In that, it was localized prostate cancer, where the radiotherapy-based regimen appears to result in a lower incidence of distant metastasis compared to the surgery-based regimen in enrolled phase 3 trial, which is still ongoing particularly. So also it has been seen approximately 80% of the men with high-risk prostate cancer localized who have been treated with surgery, they will further receive some form of therapy, either it can be adjuvant or it can be salvage RT. It remains critical for these set of patients to prevent the recurrences over here. So here it is not merely a comparison of one local therapy versus another local therapy. Don't consider it is to comparison radiotherapy versus radical prostatectomy. It is a comparison of the multimodality treatment, mainly encompassing the radiation per se, with encompassing the surgery. It is just to generate the curiosity or the interest, whatever they have seen. So they have investigated, they have tried using the role of triplet or quadruplet in the neoadjuvant. Presently, we are using a lot of triplet therapy neoadjuvant chemo ADT, either in cooperation of the radical prostatectomy or RT, and personalized therapy post-op, whether it can be RT. So whether there is any difference compared to the overall implications compared to the with respect to the toxicity or cost implications. The phase 3 data actually looking to head on with the radical prostatectomy and the radiotherapy is SPCG 15 trial, which is currently ongoing and enrolling the patients. Another interesting was the safety and efficacy of the durvalumab in combination with the neoadjuvant chemotherapy, that is gemcitabine, cisplatin, or carboplatin in patients with operable high-risk upper tract urothelial carcinoma. So it was a phase 2 data, particularly. We know the present standard of care is gemcis or gemcarbo. Here they have incorporated durvalumab, and they have seen that this combination, when given in with respect to the platinum-based chemotherapy, is safe and does not negatively impact the surgery at all. Results have been seen in the interim analysis of the phase 2 data with respect to the residual disease, mainly when the cisplatin was used. Though the results are not encouraging when gemcitabine was combined with carboplatin, but when the gem was combined with cisplatin, they have a very good result, very good PASIA HIV. So based on this phase 2 data, there is phase 3 data, which is index 3 ongoing, with where the chemo along with immunotherapy followed by immunotherapy, which is ongoing. So this is again interesting data. I'm looking forward to look this study and the phase 3 outcome. Let's see. So another was from the Dr. Adra et al., where she mentioned the role of high-dose chemotherapy in testicular cancer. What are the evidence, present evidence? We know that high-dose chemotherapy is an effective salvage therapy in refractory DCTs or relapsed DCTs. Presently available regimen we use are one is etoposide platinum-based regimen or TICE regimen, 2004 triplet 4-drug combination. So with this, it has been seen that cure can be achieved in those patients who are upfront refractory or mediastinal energicities or who have been progressing with the brain metastasis, or particularly those with Sanchuri site disease, either in the brain or the testis. So they have seen, they have evaluated, they have looked into the difference of how the high-dose chemotherapy fares when compared to the standard chemotherapy, standard dose therapy in these set of patients, and also how the minimal residual disease post high-dose chemotherapy acts as a biomarker in further selection of these patients to further either going ahead with the transplantation or not. So, very good review article by Dr. Adra et al. In this set of patients. Next abstract was which patients in metastatic hormone-sensitive prostate cancer would benefit more from androgen receptor pathway inhibitor or a taxane-based pathway inhibitor. Presently, we know the standard of care for metastatic HS disease. We have either it can be a peace regimen with abiraterone or arasons. We have a darolutamide, or we can have a only docetaxel or taxane-based combination regimen. So it was a IPD, individual patient data meta-analysis, top-cap meta-analysis, what it's called, which had concluded around 5 meta-analysis, 5 larger phase trials, included where Latitude and Stampede also in these trials, and was seen the page the paper in this large meta-analysis data. What it was seen in those patients who are young, higher BMI, and not that high burden disease, who are in the low burden disease, they benefited more in hormone sensitive prostate cancer. They benefited more with the androgen receptor pathway inhibitor when compared to the taxane-based therapy. And those with high burden disease, the benefit was almost equivocal compared to either ARPIs or a taxane-based therapy. So in those with it was finally it was concluded in this major analysis. Still, they are able to bring out the paper that compared to in this low burden disease, ARPIs, androgen receptor pathway inhibitor based therapy, do much better and also lesser toxicities in this set of patients. Another the data regarding the seminoma was the retroperineal lymph node dissection in stage 2 seminoma and present strategies and controversies which are going. Here they had seen the role of in stage 2 A and B seminoma, the role of nerve radical retroperineal lymph node dissections. Particularly since now the minimal surgeries are coming up in a big way associated with a lesser morbidity, they are putting that it's able to achieve around 100% cure in around 10 to 30% of the patients who have been relapsing particularly. And also on the long term, you avoid toxicity. If there is a relapse, we again subject them to further therapy, either it can be a BEP or a retroperitoneal radiation therapy. So this nerve sparing radical retroperitoneal lymph node dissection helps in omitting these toxicities. So also again there are further role of looking into these after the nerve sparing lymph node dissection, whether there is any role of adjuvant 1 cycle or 2 cycles of chemotherapy in those high-risk patients to prevent the recurrences or the relapses rate. So one of the interesting article coming up again, let's have to wait for the complete trials and results. This was the cosmic data. Another data was the cosmic 313, where Cabo in combination with the nivolumab and ipilimumab and previously untreated advanced renal cell carcinoma. We know nivo-ipi is have been coming up in the standard of care in the renal carcinoma advanced RCC. What is the benefit of adding triplet? This was the cosmic data basically, and the follow-up of after 45 months, it was seen the triplet in where cabozantinib in combination with the nivo-ipi continued to demonstrate a PFS benefit for the doublet in advanced RCC. So there was no, however, there was no difference, or OS difference was not attained in both the arms. Only the PFS difference around, I think around 8 months of PFS difference was seen. And safety was again consistent with the previous usage of Nivo and the previous usage. Uh, uh, Exploratory, some of the conclusions was done based on the machine learning model, where like they have seen that some M2-like macrophages were seen in these patients which have a high IMDC score or a poor risk disease. So it has been postulated these triplet combination may do better with these patients who have these M2-like macrophage mediated immune suppression. So these may be certain sort of patients. Also, they showed that whenever we're choosing a triplet regimen, usually it is better when you have a patient with high burden disease and you want a response rate too early, so that you can take the advantage of the response rate attainment of the TKI. So and later the durability action of the immune checkpoint inhibitor. So this is the cosmic data, long-term data of the triplet in combination with the doublet in advanced RCC. Another from the RCC was nivolumab combined with the cabozantinib versus sunitinib from previously untreated advanced RCC. This is a follow-up result from the segment 9-year trial. We have been using nivo and cabo now, and we have been seeing there is a good improvement in the data. We have the survival benefit, we have the PFS benefit also. And with this median 65 years, almost 5 years follow-up, the safety and tolerability was not an issue. It was manageable, and the results still 5 years also it continued to support the use of Nivo and Cabo upfront in this set of patients with advanced RCC. Also, there was a subcutaneous formulation of the nivolumab available, and they have seen that the results almost comparable when compared to the standard IV dosing. So that also can be helpful for the patients who want to omit the IV dosing. So they have an option of subcutaneous nivolumab can be used as an alternative in this set of patients with advanced RCC. Another was from the same TechMed 274 group, which showed that adjuvant nivolumab versus placebo in a high-risk muscle invasive urothelial carcinoma, where they reviewed the additional efficacy outcomes, including the overall survival in patients with muscle invasive bladder cancer. So the extended follow-up, what they have seen that nivolumab, adjuvant nivolumab in those high-risk patients in muscle invasive bladder cancer continue to show the DFS benefits compared to placebo, regardless of the prior treatment with neoadjuvant chemotherapy, whatever it was. So it continued with the DFS benefit. However, interesting was OS data from this interim analysis. There is a favoring, OS data was favoring towards the use of adjuvant nivolumab in certain set of patients, like those with high PD-L1 tumor expression more than 1%. There was a benefit in OS data, favoring OS data in this set of patients with use of adjuvant nivolumab. Safety signals again remains the same. And this also demonstrated additional support this nivolumab can be a standard of care in high-risk metastatic muzzle-invasive bladder cancer after surgery and regardless of prior neoadjuvant chemotherapy. Again, there is a substance formulation of nivolumab which can be used in this set of patients. Another data which has been presented was from the Niagara group, where additional efficacy and the safety outcomes and the exploratory analysis of impact of PAPCR on long-term outcomes were presented. Niagara, we know the perioperative durvalumab in muscle-invasive bladder cancer. Niagara demonstrated the significant clinical and the statistical improvement in event-free survival and overall survival. OS was 0.75 with 10% improvement in the PAPCR rate. There was the Niagara, and in the durvalumab arm, what's important was the risk of metastasis-free survival was reduced by 33%, and the distant recurrence was reduced by 31%. So the perioperative durvalumab plus neoadjuvant chemotherapy, it improved both the EFS and OS in both patients who achieved PAPCR and also those who achieved non-PAPCR in this exploratory post-hoc analysis particularly. So the benefit was equal for both, whether you actually have PAPCR with this perioperative or non-PAPCR regimen. They both favored having a good improvement in the EFS and OFS benefit. And also the immune-mediated adverse events were low grade and consistent with the known profile of durvalumab. This is the repetition of the stopgap meta-analysis which we discussed, where ARPI is better in patients with low tumor burden, the same is repeated. And another thing interesting was the Keymaker UO3, which was a sub-study of 03P, where pembrolizumab and targeted therapy, which is a bezutifan combination for advanced clear cell RCC was tried. In this phase 2 data, where they had tried the various combinations, basically pembrolizumab in combination with bezutifan, lenvatinib in combination with bezutifan, in this chemorefractory set of patients. And it was seen that lenvatinib with bezutifan combination had a high response rate to the tune of 46% and a PFS benefit of 12.6 months. Remember, these are chemorefractory patients who are already received 2 or more prior lines of therapy. So also the pembrolizumab in combination with the bezutifan had a similar results when compared to the bezutifan monotherapy, but the better one was lenvatinib when compared with the bezutifan, and adverse events were again manageable and consistent. This result showed the promising clinical activity of this combination lenvatinib and bezutifan, that too in this chemorefractory set of patients, particularly in second or third line subset. So we have one more armamentarium in our management of the this set of patients. Another, the upcoming was understanding the radioligand therapies, basically the PSMA-based therapies in advanced diseases and how these combinations of sequencing are helping. So we know we have been using lutetium-based therapies, 177, the PSMA radioligands are new acting, and we have been using in those patients with prostate cancer who have progressed on ARPIs and taxane-based regimens. So important is to look for PSMA theranostics, basically to balance the efficacy and toxicity. We know myelosuppression still holds a good toxicity. So important in picking up the radioligand, looking how to balance the efficacy and toxicity. So there are multiple researchers going on to see which patients respond better, also to know the predictors of response and mechanism of resistance in this form of radioligand therapy. Again, interesting article coming up, which may come up in a long way. We know the prostate cancer patients live long. So after initial therapy with abiraterone or ARPIs and then taxane, again we are left. Patients still have the good PS, then PSMA radioligands has their way to go in this set of cases. And last but not the least, which was presented was the impact of salvage therapy on the functional outcome and the quality of life. So important was the quality of life consideration, which was mentioned to be standard component of all treatment related diseases. So whether it is whatever age, particularly in our setup when we are targeting the entire population, the pediatric assessment has to be done. The quality of life consideration has to be taken, particularly the PROM, the patient-related quality of life. In whatever the studies presently done, has suggested that there was a mild to moderate impact, but we are not actually measuring what that matters. We are moreover bothered about the result particularly. So the emphasis has to be given particularly towards the patient-related quality of life, and trials are required to reduce the exposure or avoid castration, particularly in these set of patients in prostate cancer, because to minimize the toxicities or maximize the quality of life. So much of the discussions here in this abstract were mainly to how to attain a quality of life or patient-related healthcare outcomes, and what are the innovations which can be managed or to address the complaint in these set of patients has been discussed. And again, a very much up to article in present scenario, since in this prostate cancer particularly because elderly patients, long time frame of exposure, so important in managing the quality of life consultation. With this, I conclude my talk and thank you, sir, for this opportunity.
Thank you, Kaushik, for such a clear and crisp presentation on ASCO GU update. So next, the talk will be delivered by self. That is I hope my slides are visible and I'm audible clearly.
Yes, sir. Yes, sir. Please go ahead.
Okay. So I'll be speaking, addressing to extend the survival in metastatic urothelial carcinoma. So the treatment approaches have evaluated the maximizing the overall survival in metastatic urothelial carcinoma. So the most important factor is whether the patient is platinum eligible or not. If patient is platinum eligible, is he or she is cisplatin eligible or not? So we have three approaches. First is wait and watch. In that, the patient receives first line of chemotherapy and remains on wait and watch policy until disease progression, and the second line therapy is initiated thereafter. The second is switch maintenance, where the patient receives first line chemotherapy, and if patient has responded to that first line chemotherapy, then patient is switched to IO maintenance until disease progression or unacceptable toxicity, and till patient is disease free or patient there is no disease progression, and once there is disease progression, the second line therapy is initiated. Third one is continuation maintenance, where patient receives chemotherapy along with the immunotherapy and then followed by a fixed number of cycles. Chemotherapy is withheld, whereas IO maintenance is continued until unless disease progression. And once there is disease progression, the second line therapy is initiated. As we can see clearly, the second approach, that is switch maintenance, is as of now giving the maximal benefit in the terms of overall survival. So this is wait and watch. Here patient receives the fixed number of chemotherapy in first line and remains on wait and watch until disease progression, then receiving second line immunotherapy. With this approach, the median overall survival achieved is around 16 months, 5 to 6 months with the first line chemotherapy and around 10 months with the second line pembrolizumab. As you can see in the Kaplan-Meier curves, the second line pembrolizumab is associated with improved overall survival. Whereas if you talk about the switch maintenance, where the patient received chemo alone, followed by switch immunotherapy maintenance until disease progression and the second line therapy. Then what is the data supporting this? This is Javelin Bladder 100 trial, where patient with unresectable or advanced or metastatic urothelial carcinoma was, after receiving a fixed number of chemotherapy cycles, patient who has responded in the terms of stable disease, CR or PR, randomized to either avelumab maintenance every 2 weeks or best supportive care, with a primary endpoint with overall survival and multiple secondary endpoints. Here you can see that with this switch maintenance policy or approach, we are getting around 30 months of median overall survival, which is unprecedented and unheard of in metastatic urothelial carcinoma, as compared to 20.5 months in best supportive care alone, and with the hazard ratio of 0.77, that is at least 23% reduced risk of progression or death. The median PFS also with this switch maintenance approach is higher with avelumab plus best supportive care, that you can see that 5.5 versus 2.1 with significant p-value and hazard ratio of 0.54. And also this benefit is irrespective of the number of cycles patient is getting. You can see that patient getting 4 cycles or 6 cycles, they have almost similar hazard ratio, 0.69 and 0.66, and they are getting benefit in the terms of overall survival. Also, this benefit is irrespective of what platinum patient is getting. Even in carboplatin plus gemcitabine combination followed by switch maintenance, we are getting significant improvement in overall survival as compared to best supportive care alone. Same as seen in cisplatin plus gemcitabine followed by avelumab maintenance. Also, the overall survival and progression-free survival benefit with switch maintenance, that is avelumab maintenance, is irrespective of response to chemotherapy. That means whatsoever is patient respond, either stable disease, PR or CR, the benefit is achieved by the patient. You can see the hazard ratio, although is better in CR and PR, but with stable disease also hazard ratio is of 0.84. Now talking about what Asian subgroup has achieved in Javelin Bladder 100 trial, there were around 150, if specifically mentioning, then 147 Asian patients who, after receiving chemotherapy, responding to chemotherapy, were randomized to avelumab or best supportive care with a primary endpoint with overall survival. One can clearly see that the similar benefit is achieved in Asian patients as seen in the overall population. 28.7 months of overall survival as compared to 18.2 with the best supportive care, and 3 times higher PFS in as compared to non-avelumab maintenance patients. Coming to the safety profile, as we are managing the metastatic disease, so apart from increasing or improving the overall survival, we have to maintain the quality of life. Although there were adverse events seen in avelumab plus best supportive care, but if you talk about grade 3 or more adverse events, there were hardly any subset which has more than 5% grade 3 or more adverse events, except for biochemical abnormality, that is increased amylase and increased lipase. All other grade 3 or more adverse events were less than 5%. To be precise, it was 1 or 2%, as we can see in this slide. Now, the efficacy of this data of Javelin 100 trial has been confirmed in real-world heterogeneous population. The data what we are having as of now is accounting for over more than 1,200 patients. So we can see the OS rate in various trials. One is JB100, Javelin Bladder 100, that is 71.3, 12-month overall survival. In Evidence and Ready trial, it is amounting to around 65 to 70%, with the median PFS is similar in the real world study as seen in Javelin 100 trial. This is evidence study, that is ongoing multi-center study, non-interventional study with locally advanced or metastatic urothelial cancer treated with avelumab switch maintenance, where the primary endpoint was overall survival from the start of the Bavencio treatment. So it is not from the chemotherapy treatment. Chemotherapy treatment, the overall survival, that is secondary endpoint. So here how the sequencing was being done. Patient receives first-line chemotherapy. Once patient is responding to chemotherapy, patient receives switch maintenance with avelumab until disease progression. And once disease progression, patient receives antibody drug conjugate enfortumab vedotin. And with that, unprecedented median overall survival of more than 40 months was observed in this study. So now coming to approach to maximize the overall survival, the other approaches, that is third approach, which we were talking about. Here, there were multiple trials had happened where chemotherapy upfront was given with immunotherapy, followed by immunotherapy maintenance. As you can see that two trials of Atezo plus or Pembro plus chemo were negative trial. The one trial, although it was positive trial, as you can see, Checkmate 901, but hardly it has given the median overall survival benefit of 2.8 months and negligible PFS benefit, as we can see in the following slides. So this is Checkmate 901, where the patients were randomized to Nivo plus chemo or chemo alone, followed by Nivo maintenance, primary endpoints being OS, PFS. Now, if you talk about now median PFS, here the PFS is 7.9 months with Nivo plus chemotherapy, whereas only with 7.6 months with chemotherapy. So hardly 0.3 months. So it accounts for around 9 to 10 days benefit. And coming to overall survival, the overall survival delta, you can very clearly see that it is only around 2.8 months. Whereas with the avelumab maintenance, it was around 10 months benefit. So although we have two positive trial, one is Bavencio JB100 trial, the other one is nivolumab 901 study. Bavencio has taken both platinum eligible cisplatin and carboplatin, and nivolumab has taken only cisplatin eligible. So selected population in nivolumab. Median follow-up was prolonged for Bavencio, whereas it was 33.6 for nivolumab. Indian patients were included in Bavencio, not in nivolumab. And comparator arm actually received immunotherapy 74% patient, whereas GEMS is followed by avelumab maintenance received only by 11% patients. So there will be a little bit discordance in the data. Now you can see the benefit, 3.7 months benefit in PFS with avelumab switch maintenance, whereas only 0.3 months with Checkmate 901, and 8 months overall survival benefit with avelumab maintenance and 2.8 with nivolumab. So now various other combinations were being tried to maximize the overall survival in the term of IO plus TKI, and IO plus antibody drug conjugate. IO plus IO and IO plus TKI were the negative studies, whereas the IO plus antibody drug conjugate, that is enfortumab vedotin, was a positive study. It met its endpoint, primary endpoints, PFS and OS. This is EV302 Keynote A39 trial, where patients were randomized to enfortumab vedotin plus pembrolizumab vis-a-vis chemotherapy. There were no maximum treatment cycle for EV, but 35 cycles for pembrolizumab. Primary endpoint were PFS and OS. Now you can see that the primary endpoints were achieved in this study with a hazard ratio of 0.47, that is 53% reduced risk of death. The median overall survival of 31.15 months versus 16.1 in the chemotherapy arm. But, as compared to the Bavencio study, you can see that lot many patients are having grade 3 or more adverse events, and that too skin reaction, neuropathy, and other events. So now we have these approaches where the maximal benefit was seen in the Avenance JB100 protocol, where patient receives chemotherapy, avelumab maintenance, antibody drug conjugate as enfortumab vedotin. With this, the survival, unprecedented survival is achieved, that is 40.8 months. With no other therapy, whether it is nivolumab or infotumab plus pembro, we are not achieving this much benefit. So to summarize, the metastatic urothelial cancer is not uncommon and the long-term survival outcomes are dismal. So the treatment is evolving. Platinum-containing chemotherapy has higher initial response rate, but responses are not long-lasting. Maintenance avelumab significantly increases overall survival, which is irrespective of first-line chemotherapy, the platinum partner, the duration of chemotherapy, response to chemotherapy. Nivo plus chemotherapy, although a positive study, but the results, there are only minor increment in PFS and OS as we have seen. Pembro plus EV data looks good, but we have to be cautious about the toxicity profile. Finally, although the best sequencing pattern is still evolving, but chemo followed by avelumab maintenance followed by antibody drug conjugate is as of now giving us the maximum benefit of around 40.8 months, which is unprecedented and unheard of. Thank you. So thanks for the patient listening. So I'll be next inviting upon Dr. Simbala Saran, who is from Datar Cancer Genetics. He'll be speaking on minimal residual disease, the compass of precision oncology. Dr. Simbala Saran.
Thank you so much, Dr. Dubey sir, and thank you so much for the organizer for this excellent opportunity. So let me share my screen and please let me know once the screen is visible for everybody. Is this screen is visible for everyone?
Okay. Yes, sir. Perfect. Please go ahead.
Yes, sir. It is visible and you are clearly audible.
Thank you so much, sir. Okay, so good evening to everyone once again. So today mainly we are going to discuss about the minimal residual disease, which is called MRD, which is very well known in the hematology malignancy. But today mainly we are going to discuss how this is evolving in solid tumors also. So today in talk, Dr. Meghna and Dr. Dubey sir and everybody have talking about most of the solid tumors like breast cancer, prostate cancer, and also urothelial cancer. So I'm just going to showcase in each of these cancer how we can improve the patient's OS and PFS benefit by using this MRD technology or MRD technique, how we can improve to the next level. So with this one, I like to start my presentation. These are some of the basic disclaimers about my employment as well as the information I'm sharing over here. So with this, first, let's understand every solid tumor is going to be different because the cell involved in each of these solid tumors are totally different. And the mutation which turn them or the hallmark of cancer which turn this normal cell to become a cancer cell is totally different. So it is always wise to understand the tumor biology to the greater extent. And then when we are starting and selecting the accurate treatment, that's all about the precision oncology, right? So that will help us to get the best treatment for the patient. For an example, if I have to say in the lung cancer, the patient may have EGFR mutation. And now we are going to the extent level, which exon of EGFR mutation is there. Exon 18, exon 19, or exon 20 or 21. Among these, if the patient have L58R mutation, the patient will respond to certain drug combination of EGFR with the TKI and bevacizumab. So like that, we have understand to the various extent that the tumor biology and the genomic mutation associated with this very much important because they are the driver of the cancer. So if you look at the left hand image over here, the normal cell, when it is becoming a precursor cancerous cell, and then the driver mutation is getting selected, and then it is becoming a primary tumor. So the primary tumor may have one mutation, which is monoclonal mutation, which can be EGFR driver mutation or ALK driver mutation or any other driver mutation, depends upon the cancer type. But sometimes it can be polyclonal mutation also. In the primary tumor itself, we may have one or two driver mutation or co-driver mutation, both these drivers are beginning itself, it started to evolve together, right? So the progression can be a linear progression or it can be progression at the parallel level. So if we need to understand this tumor biology, what is the main challenge we have? The first challenge we are going to have in the solid tumor is intra-tumor heterogeneity and inter-patient tumor heterogeneity. So both these things are very, very difficult to compensate. So that's why sometimes when the clinicians over here, when they are selecting a tissue block for sending to the NGS lab testing, one lab will give you one result and another lab will give you another result. Which one to trust? One lab given the pathological mutation, another lab saying that there is no mutation. Which one to trust? One in-house testing I have done, IHC is so positive, HER2 is so positive, but when I send for the testing, nothing comes up. What to do next? So these kind of challenges are there in the tumor biopsy. Okay, what is the next alternative? We have the blood sample. So in the blood, various tumors will shed the circulating tumor in a different manner, and that can be utilized for doing the genomic profiling to understand the tumor biology. But the key word is the circulating tumor DNA or the circulating tumor cells or the cell-free DNA secretion by the solid tumor is going to be different from one cancer to another cancer, which I am going to shortly show. So in the blood, you have circulating tumor cells, you have ctDNA, you have cfDNA, you have exosomes, everything you can utilize pool together to do the genomic profiling to understand the tumor biology completely whenever the tissue option is not available for us. Okay, so where to use this liquid biopsy? You can use it for different variety of reasons. You can use it for early detection after the surgery, whether the relapse is going to happen, or you can use as a prognostic marker, or you can combine with the MRD, which I am going to talk in a lengthy manner, and you can use them for the selection of treatment therapy, and the drug choice you have selected is the working or not, so which means the response to the therapy. Whether any clonal population is getting ready after the therapy you are starting. For an example, you have started with osimertinib, and then the EGFR mutation is going to develop some other clonal population, whether any resistance mechanism is going to develop or not. So that can be identified, whether the patient is going to get relapse from the cancer treatment or not. So all those things you can be able to identify by liquid biopsy. Okay, so tissue biopsy is good. Say there are certain limitations are there. And liquid biopsy is good. There are many things we can utilize with that one. Is it both of them are good or bad? So that's what ASCO you have suggested recently. Always molecular synergy, which means tissue plus liquid together. Whenever you are doing it, you have huge benefit. We have huge benefit out of it. So minimum of 15% to 20%, you can identify actionable mutation. Only I'm talking about actionable mutation whenever you are doing the tissue plus liquid biopsy together. Either you can do at the beginning itself, in the left-hand side, you can see the matched therapy of a tissue versus the liquid biopsy together at the diagnosis time itself, you can do it. Or you can do at the time of disease progression. This is very, very important. Why? This is the information which is going to serve for us as the MRD information in the later segment. So either at the time of diagnosis, we can able to do it, or at least the first time of progression. Please let's do either tissue plus liquid biopsy together so that the patient's entire tumor biology is understood. And in the right hand side, if you look at in the breast cancer, more than 14,000 breast cancer patients, if you do seen, the green color marks are in the tissue biopsy and the orange color marks are in the liquid biopsy. So both of them almost equal. You can detect all the different alterations and certain mutations. It can able to detect much better in the liquid biopsy. Most of those mutations will be a resistance mechanism to certain treatment. For an example, it can be a aromatase treatment or it can be any other treatment. So then the mutation, when its clonal population is evolving, the tissue biopsy cannot able to pick it up, but the liquid biopsy can able to pick it up better, basically. So that is the rationale behind combining the tissue biopsy and liquid biopsy. So this is the short summary how the liquid biopsy and the tissue biopsy can compensate together for us, basically. Okay, so compensating together, what we are trying to achieve. If you look at this entire image, there are 4 different types of clonal evolution can take place. There is a thing called linear evolution, there is a thing called branching evolution, and neutral evolution, and punctuated evolution. So all this evolution of the tumor biology need to be understood. Means the tissue biopsy along with the liquid biopsy is the key to get the information for us basically. As I mentioned, okay, the liquid biopsy is going to be helpful, but as I mentioned, the tumor fraction of the shedding capacity of the particular solid tumor is very, very, very important in order to accurately understand the clonal population and also the mutation, the VAF percentage of the mutation to presence in the particular patient's blood sample. So that's why we need to check it out whether patient's tumor fraction is elevated first in the blood level by checking the circulating tumor cells, or at the DNA level, ctDNA level, we can measure it to say that the patient have the sufficient number of circulating tumor cells or the ctDNA fraction. So here in the right hand side, you can see the image, right? So from the SCLC, from the liver cancer, from the colorectal cancer, if you move towards the right hand side, which is the glioblastoma, the top bar, you can see that 17.7 is for the 17.7 is for the small cell lung cancer. So that means the shedding capacity of the ctDNA in the small cell lung cancer is more. Liver cancer is more. Colorectal cancer is more. So that's why in this cancer, you can very well use the MRD, because MRD, you are going to follow it up. What you understand or what you identified earlier in the baseline, you are going to follow it up. So for that, the blood sample, the ctDNA secreting capacity is very, very, very important. So understanding this, now you know which are the cancers you can position the MRD, how to utilize for your patients. Okay. So the MRD can be utilized in 4 different settings. Either you can use it for early diagnosis, or you can use it for the prognosis and the selection of the therapy. And after selecting the therapy, you can use for the monitoring the treatment and the response. Finally, also you can select the patients for the next line of therapy. What kind of therapy can be given? Because you need not to wait for the radiological imaging, which can take place every 3 months to 6 months. The PET scan imaging or the MRI scan imaging, which will take place every 3 months to 6 months. But the molecular progression will show way before the clinical progression or the radiological findings, basically. Right? So that's what the evidence and data I'm going to show. So thereby, you can utilize the MRD to the highest level. Okay. Let me pause here. The MRD is very important, and how to set the baseline for the MRD and how to utilize the MRD, we have seen the scientific part of it. This is where Datar Cancer Genetics want to have a tie-up with all these clinicians here. Whomever, your patients need a better treatment. So we are here to give different approaches for the MRD. The main approaches, the first approach is tumor-informed strategy. The second approach is tumor-agnostic strategy. So what we mean by tumor-informed strategy, what we mean by tumor-agnostic strategy. In the tumor-informed strategy, the patient's genomic profiling will be done at the tissue level or at the blood level to understand all the 395 genes at the base level, including the tumor mutation burden will be done. Then those mutation, the tumor-informed mutation, the patient's affected mutation will be carefully picked up, those which can be a driver mutation or the mutation which can cause the damage to the clonal population can be picked up and validated. Very importantly, it will be validated using droplet PCR. It's like you are doing the NGS, but confirming it with the IHC or confirming with one more orthogonal testing. Here, the orthogonal testing is going to be used as the droplet PCR, which is well established. The limit of detection is 0.01%. So the quality of information it is going to confer your patient is accurate. So one side of it is tumor informed, and the another side of it is the tumor agnostic. In the tumor agnostic also, the same pattern will be followed, and then we will be baseline once it is set. From the baseline, we will be picking up the mutation, whatever you wanted, either 2 or 4 or 5. Currently, we are starting with minimum of 2, so that we can able to follow and track those mutations, what happened. Whether the treatment, whether worked for the patient or not, whether the mutation is coming up, it's like normal CA level or CA 125 level or whatever the biomarker you are having. But this biomarker is personalized biomarker to the particular patient, to the particular tumor, to the particular mutation. So it's even more precise, even more personalized for the particular patient. We can able to monitor so that the accuracy is going to be on the high side. So what we needed a tissue block, We needed the blood sample, which is about 30 ml, and then routine, the baseline testing will be done of 395 gene to understand it. And then from there, we will be doing the sequencing of the droplet PCR to understand the mutation accuracy, and then follow it up every 3 to 6 weeks. You can follow it up. So basically, it's a 1 month to 1.5 months. You can follow it up. Normal blood sample you can give and to understand. So it's an invasive technology. So the patients will not have much sufferance over there, and you can accurately tell that whether the treatment is working or not. The major challenge current treatment is you take n number of therapy. Recently, sir have presented the data, all the doctors. So most of the combination therapy or most of the immunotherapy or most of the targeted therapy, the response rate will be lesser, or they will be responding to only the certain period of time. Basically, when they are going to relapse, the clinical trial says that they will have 6-month relapse. But when we try in our patient, they will be relapsed in 3 months. Some patients will living for 32 months. We don't know. So median data is only available. But whether our patients will come in this category or that category, how to know? So that's why this MRD is going to help you monitoring whether the patient's selected drug is going to work out. So that the economically, patient also will get benefited out of it, because unnecessarily we need not to give another 3 more cycles or 4 more cycles of immunotherapy or targeted therapy combination. Okay, currently these are the organization, or these are the biotechnology organization. They are utilizing this ctDNA based MRD testing. Some of them are using tumor informed one, some of them are using tumor naive one, but only in Datar we are using both informed and naive technology together. So that means combination of tissue biopsy and liquid biopsy together, right? So always concurrent test is going to be helpful for us. So like that, if you look at the names, none of these names are very small names. Already you guys knows that all of them are from foreign countries. But in India, it's a only company, which is Datar Cancer Genetics, is going to do this for detecting the MRD for our patients. You can utilize it, and there are a lot of publications also available. We have proven that benefited the clinical patients. So here you can, just for the comparison of the commercial one, so as I just mentioned it out right now, the tumor informed plus tumor naive is going to be utilized. And more importantly, certain organization, the commercial organization, going to detect only for the CRC, breast and lung. But in this MRD, we are going to utilize for multi-cancer. So that means irrelevant of any cancer, whether breast cancer, lung cancer, colorectal cancer, any cancer, you can utilize this technology. These are some of the other platforms which is in the market, not yet available, only in the research setting. But again, if you look at that, most of them are either using tumor naive or tumor informed, but there is no combination available. Okay, so the technology is supreme. The technology is available with us. Where to apply and how to apply? Will it really benefit the patient at this moment? Yes, that's what we are going to show. Let's take the scenario of case 1, where the patient have colorectal cancer and they have undergone for surgery. Most of the surgery after done, what we will do? Wait and watch. In urothelial cancer, wait and watch. What we can do, by understanding the tumor biology of the patient who have undergone for the biopsy or the surgery, take that as a baseline. Let's do the genomic profiling. And then when we are doing the patient stratification, risk stratification, whenever the patient's ctDNA is positive, whenever the patient's ctDNA becoming positive, which is way before the radiological progression, we can clearly say that that patient can get the benefit out of adjuvant chemotherapy in colorectal cancer. This is the evidence in front of you for the early diagnosis. So this is the clinical trial data, which was set up in the stage 1 to 3 colorectal cancer patient who have been identified as ctDNA positive in the stage 1 to 3. They have the higher risk of 7-fold increased risk of recurrence after surgery within 30 days. Within 30 days. And whenever the ctDNA is positive, 40% risk of disease recurrence when compared to the ctDNA negative patient. So it's very clear statement. Whenever the ctDNA is negative, we can avoid chemotherapy. Whenever the ctDNA is positive, we need to give the chemotherapy, because the data suggests that the patient have the high chance of relapse. The third important point, if you look at that, the ctDNA serial analysis on month, it's clearly showing that recurrence in the 16.5 months before the conventional radiological imaging, we can able to find out whether the patient is going to have the relapse or not. The recurrence is going to happen or not. So that is the very importance of clinical application of the MRD testing you can utilize. So this is the clinical trial design. So just now I mentioned the chemotherapy can get the benefit. So here is the example. Here is the evidence basically. This is the clinical trial, phase 2 clinical trial, non-inferiority clinical trial by dynamic study design. If you look at the stage 2 colorectal cancer patient, so 455 patients have been allocated randomly 2:1 ratio. Whenever the patient have ctDNA positive, the patient were subjected to adjuvant chemotherapy. Whenever the patient have ctDNA negative, they have only wait and watch. That is the standard of care right now, right? So that's the same thing has been followed up for the patient. So whenever the patient have the ctDNA positive and undergone for the adjuvant chemotherapy, the recurrence-free survival, they followed up to 37 months. The recurrence survival for 2 years is the highest, and the PFS benefit also benefited for the patient. You can look at over the data over here. So whenever the patient undergone for the adjuvant chemotherapy, the patient 30 number patient, at the end of the therapy, when they become ctDNA negative, their recurrence-free survival and the overall survival is also on the higher side of it. At 12 months, their survival rate is 100%. At 2 years, which is 97% when compared to the ctDNA positive patient after the treatment. I'm talking about after the treatment, even after the treatment, if they are becoming positive. Okay. So this is also another different study where the cohort number is on the higher side of it. And also they are in the different multiple stage. Only stage 2 earlier study, here stage 1 to stage 3 basically, right? So 16,000 patients were being recruited, and clinically they have been followed up for almost 615 days and 730 days for the relapsed patients. So again, the MRD, when they follow it up, what they understand, post-operative, when they become ctDNA positive, right, the patient's recurrence-free survival is lower when the ctDNA is positive. When the ctDNA is negative, the patients survive longer. That's a very clear statement message. Even 2 to 8 weeks after the surgery or any time post-surgery, while during the surveillance also, they have measured. It's a very clear, crystal clear statement. When the patient has ctDNA, you need to act on it, and that way it will benefit the patient. So again, whenever the patient has ctDNA negative, the patient doesn't have any benefit from the adjuvant chemotherapy, ACT, adjuvant chemotherapy. No, not at all going to get benefit. So it's a very clear statement why we need to put unnecessary risk on the patient whenever they don't have the ctDNA negative. So that's a value message it can bring to the thing. The another example I'm going to show in the breast cancer. So plasma match trial. So when the ctDNA measured in the breast cancer patient, and when the liquid biopsy along with the tissue biopsy and the droplet PCR was done, they understand different mutation, which is ESR1 mutation, HER2 mutation, AKT mutation, and all those things. So based on that, the patients have been subjected to different treatment options for the patients. So that also can be followed up before the treatment and after the treatment also. So this is another classical example of yearly breast cancer detection. So statement is very clear. Whenever the patient is going to get relapse or going to get extracranial metastatic relapse, ctDNA have picked up 96%. Especially the brain metastatic, there is no biopsy option is available. So only through the liquid biopsy, we can able to predict well before the patient undergoing for the huge number of metastatic and then detecting it in the radiological imaging by MRI scan in the later time. So we can detect very early. NSCLC also. All the information is going to tell us the ctDNA is going to be helpful and MRD is going to be helpful for us at the setting. So with this one, I like to thank entire panelists and also the participant for listening patiently and for this opportunity, the entire organizing committee for that. Thank you so much, sir. If any questions are here, we are very happy to share. And if any of the support needed, they are also here. I am a clinical genomist, so I can support all the report interpretation services and whatever the clinical decision you want to make, I can able to support on the same part of it. Actually. Thank you so much.
Thank you so much, sir, for your excellent talk. So here we conclude day 2. So thank you so much, everyone, for joining in today. And bye and good night, sir. Thank you so much, everyone. Thank you. Bye.